Our next presenter is Dr. Ahmed Shuaib. Dr. Ahmed Shuaib is a pathology registrar at Sheffield Orman Oncology Hospital. And his case is entitled The Good, the Bad, and the Ugly. Dr. Ahmed, you can start presenting.
Thank you, Dr. Muhammad, for granting me this opportunity to present this case today. It's titled The Good, the Bad, and the Ugly. Presented to you by me, Dr. Ahmed Shuaib, a pathology resident at Sheffield Orman Hospital, under the valuable supervision of Dr. Angel Hariri, a pathology consultant at Sheffield Orman Hospital in Luxor, Egypt. For starters, let's review the patient's clinical data. A 3-year-old female patient presented to Sheffield Orman Hospital with a huge left lung mass lesion associated with decreased air entry on the left side of the chest without fever or cough. She also had multiple enlarged lower cervical and upper abdominal lymph nodes, suggestive of lymphoma. She underwent an ultrasound-guided biopsy from the left lung mass. The examined sections revealed cores of tumor tissue, formed of spindle, stellate, and ovoid cells. These cells showed marked nuclear pleomorphism and hyperchromasia. They were arranged in a loose fibrous stroma. Mitotic count was more than 30 per 10 high power field with many atypical forms. There are also multiple foci of necrotic debris, suggestive that the tumor is or has a high turnover. Based on this biopsy, we elected to consider a wide range of differential diagnosis, covering epithelial tumor, lymphoma, leiomyosarcoma, solitary fibrous tumor, synovial sarcoma, rhabdomyosarcoma, inflammatory myofibroblastic tumor, and malignant peripheral nerve sheath tumor. First of all, cytokeratin came back negative, eliminating the possibility of an epithelial tumor. CD20 highlighted few B lymphocytes, and CD3 was highlighting few T lymphocytes. Both eliminated the possibility of a lymphoma. Desmin was focally positive. Caldesmin was negative. Both eliminated the possibility of a leiomyosarcoma. Myogenin was also negative, ruling out a rhabdomyosarcoma. CD34 highlighted endothelial cells, but it was negative in the tumor cells. STAT6 was also a negative, eliminated the possibility of solitary fibrous tumor. TLE1 also highlighted epithelial tumors, epithelial cells, but it was negative in the tumor cells, excluding the possibility of synovial sarcoma. CD99 was also NKX.
عشان خاطر افتح من عندنا حاجه خلاص ليه بقى مش ليه سيبيها هي.
Excuse me, colleagues, please mute your mics, please. One of the colleagues have his mic open. Please mute your mics.
As I was saying, CD99 was negative. KX2.2 was also negative. Both eliminated the possibility of sarcoma. ALK was negative also, ruling out inflammatory myofibroblastic tumor. S100 was negative, and also SOX10 came back negative, both ruling out the possibility of a malignant peripheral nerve sheath tumor. This extended immunohistochemistry panel that we ordered, it raised more questions than it answered. It was crystal clear that an important piece of the puzzle was missing. So we had to take a step back, revisit the patient's clinical data, and have another MDT discussion. And that's when we found the missing piece, the patient's CT scan. The CT scan revealed a huge left lung soft tissue mass, almost occupying the upper lung lobe from the hilum to the pleura, measuring approximately 7 by 9 by 10 centimeters. The CT also revealed a compressed left lower lobe, bronchus and parenchyma, with partial consolidation and collapse. The heart was pushed to the right side by the huge tumor. And then we reached our diagnosis after clinical, radiological, and pathological correlation. Findings were compatible with a pleuropulmonary blastoma. And since neoadjuvant therapy was of no help in this case, the patient underwent a left upper lung lobectomy with partial pleurectomy. The received specimen measured about 14 by 9 by 6 centimeters, covered by a shiny layer of healthy-looking pleura. Serialing of the specimen revealed a solid, fleshy, tan, grayish cut section, and that the mass was well circumscribed and replacing the entirety of the specimen. The examined H&E slides revealed a markedly cellular tumor formed of stellate, spindle, and ovoid cells, showing marked nuclear pleomorphism and hyperchromasia, with many bizarre forms. And in this slide, we can notice that the tumor is on the left side and the normal lung parenchyma on the right side. There is also a loose fibrous stroma alternating with a dense sclerotic area. There are many areas showing small round primitive cells, and there is also prominent hemangioparasitic pattern of vascularity. There is also multifocal coagulative necrosis was present within the tumor. And the tumor, as we can see in the slide, is seen infiltrating the visceral pleura. And then we reach our diagnosis, a pleuropulmonary blastoma type 3. Pleuropulmonary blastoma is a rare primitive primary neoplasm of the thorax in young children. It may arise from the pulmonary parenchyma, mediastinum, and pleura. It is classified in 3 types: type 1, type 2, type 3. Type 1 is a mainly cystic tumor, and it's usually peripherally located. Type 2, it's a mixed cystic and solid component, and type 3 is mainly solid. It can involve a lung loop or the entire lung. Dicer1 gene mutation. It was noticed that most pulmonary blastoma cases are related to a Dicer1 gene mutation. Dicer1 gene is responsible for regulation of protein expression. Patients with Dicer1 mutation are liable to developing other benign and malignant tumors, such as cystic nephroma in patients younger than 4 years, nodular thyroid hyperplasia, ovarian Sertoli Leydig cell tumors, cervical embryonal rhabdomyosarcoma, and finally, pituitary blastoma. The prognosis and decision of treatment both depend on whether it is the good type 1 or the bad type 3 or the in-between type 2, considering that generally they all look ugly, since the title of this presentation. Our take-home message from this presentation is the importance of clinical and radiological correlation. Immunohistochemistry is not a magic crystal. It's a diagnostic tool that can be of great help if used in the right context. But if you don't know where you're headed, it will lead you absolutely nowhere. Last but not least, I would like to thank Dr. Mohammed Kamal for making this event possible, and thank Dr. Angel Hariri for her valuable guidance and mentorship, and thank you all, and wishing you a happy International Pathology Day.
Thank you so much, Dr. Ahmed. Such a great presentation, great efforts. Thanks, Dr. Angie. Thank you all for attendance and listening.